Hello.
Very lovely to meet you.
Very good to meet you too.
I'm horrible sorry I'm late. And
That's okay.
it's Australia.
Nice and warm today. Very nice and warm. We are expecting a storm, but hopefully it won't come.
How are you with COVID?
In Queensland, where I am, very good. There's no cases, but in other parts of Australia, very bad. You have to be careful. That's no good.
Yeah, it's all right. Mrs. Fry.
Megan, please. Yeah, Megan.
Megan. Why did you study psychology?
Oh, that's a very interesting question. I actually didn't know. I just knew that I wanted to go to university, and I happened to go along to a university open day. And during that open day, I just happened to walk into the psychology lecture, and I found it very interesting, and I applied and got in.
Wow, that's a thing I really dislike about I think the school system international, that kids don't get teach in school their opportunities.
Yeah.
Because
yeah, I had no idea. I had no idea what psychology was before I started. So.
So then you studied, and you said that you worked with veterans. How come?
So I actually finished my high school, finished year 12 here in Australia, finished high school, and I actually went off and joined the Army Reserves at that time. And so I applied for university and I joined the part-time Army here in Australia. And that's because there were a few of my family members that had served and I wanted to go and have a go. So I enlisted in the Army Reserves, and when I was down doing my initial training, I actually got into my psychology degree. So whilst I did my psychology degree, I also did Army Reserves as a truck driver. And so I did them both at the same time. And then when I got my degree, I wasn't able to follow the paths that I wanted to follow, being getting into my clinical masters at university or being able to work with children. And so Army psychology changed at that time. And when Army psychology changed, it changed to being more clinical and less organizational. And so I went into the university at that time. I went into the Army full time as an Army psychologist. And so I started working in the Army as a psychologist in the Army. And then that's where I've spent the rest of my career, working with soldiers who are still serving or ex-serving.
Well, what does this mean from organizational to systematic?
So organizational is where military used to just do recruitment and selection. So they used to assess soldiers for which job they wanted to do in the Army and to see if they were suitable. So that was the organizational role in psychology. And then the clinical role was working more with people, so doing more counseling and clinical based work, which was what I wanted to do, not just assessments to say, yes, they're suitable for a job.
And when did this change?
It would have changed probably in the early 2000s.
And before this, there was no officially counseling for Army counseling for veterans.
There was just not on the scale, not as much. Army psychology was focused in other directions, most in organizational. There have been other counseling services available, probably more external than internal. A lot of it was outsourced, but then they brought psychologists into the army, and particularly because around that time there was more deployments happening with the start of East Timor. So there were more deployments happening. So they wanted more psychologists in those roles to be able to fulfill, have psychologists on the ground to support soldiers while they were serving.
Sound. You said that your family members did serve. Were there in conflict?
Yes, my dad served in the Vietnam War. And then my uncle served in the SASR regiment. That's our top secret elite organization. So he served there, but yes, my father served over in the Vietnam War.
So
he was conscripted.
So he didn't seem to have told you bad things or scary things, or no, otherwise you wouldn't have gone there, no?
True, yeah. No, my father didn't talk very much about his service at all. And I guess it was very honored in my family. I remember when I was a little girl, I used to go with my grandmother and my other uncle down to our Royal Military College in Duntroon, where they train our officers. And I was a little girl, and my grandmother and uncle used to take me down to watch my uncle in his marching parades. So it was always very honored in my family service and respected and valued.
And well, did you experience them before you started your army work as an army psychologist about PTSD of veterans?
I had, because my father probably got diagnosed with PTSD in my adolescence. So even though he served in Vietnam and he did some part-time service after then as well, he was not diagnosed with PTSD until my adolescence. I remember he became diagnosed. I still didn't understand too much at that time. And of course, it wasn't till I, started my psychology degree that I understood more, and trauma became a very specific interest of mine.
So you are doing a schematic, you're working schematic therapy.
Schema therapy, yes.
I just read
Schema.
that 30 that it's got invented because 30% of people that do cognitive therapy, that it doesn't work with them.
I don't know what the rates are, but I would believe that. So I spent 5 years working as a contracted psychologist for our Special Forces soldiers in Sydney. And during that time, I was really only trained in cognitive behavioral therapy, and I found it incredibly limited. We weren't able to provide, wasn't very useful in terms of treating these soldiers who were doing back-to-back deployments in Afghanistan at that time. And that's where I started my schema therapy journey. I did my training, my first schema therapy course around that time. I sort of did a number of different therapies. I tried acceptance and commitment therapy and dialectical behavior therapy. And then I did my schema therapy because I found all of the other therapies very limited. Whereas schema therapy is very useful because it looks at, I guess, what's happened in your life and how has that impacted you. And that was the start of my schema therapy journey.
But schema therapy looks a lot at what happens in the childhood, no? What has that to do with exceptional trauma, like in a conflict area?
That is a very good question, because when I used the traditional schema therapy approach to military personnel, it didn't work very well. It worked better than some of the other therapies, but it still didn't work very well. And so in the past almost 10 years, I've been sort of trying to adapt, you know, everything that I've worked with soldiers and with what I know as a psychologist, to be able to try and find an approach that really worked for them. And what I've learned is that the way that the military trains the person to come into the military has a profound effect on them. And unless the schema therapy model actually allows us to understand that effect, it actually allows us to understand that this self prior to the military, and anything could have happened to the person in that time. And then the person came into the military and the person got trained to be in the military. And that has a very profound effect on the individual. And then, you know, when they leave service, then that's sort of another stage. And schema therapy allows us to understand, well, what happened in your life before the military, and then what happened in your life during the military, and where you're at in your life now and where you're going. And it helps them make sense of that and understand, what are the beliefs I've developed? What are the behaviors that I've developed? What's helpful and not helpful? And how do I get my needs met in a healthy way now in my life now?
How exactly does
that version?
How exactly do you work with them?
With military people?
Yeah.
With the schema therapy?
Yeah.
Yeah, so I've developed a model that helps them understand. So it makes them think about, well, when they came into service, how did the military shape them? So we help them understand the beliefs and the behaviors that the military shapes in them, and then gets them to think about, well, what's helpful or not so helpful about that. So one of the things is military people tend to have very high unrelenting standards. So these standards of performance and achievement and needing to go above and beyond and succeed and achieve. And that's drilled into many military people, because that's something that's very much required for operational service and for combat, the need to keep going, the need to fight, to persist under harsh conditions. So we help them understand that maybe their standards are maybe not so how helpful are these standards in their life now, and start to make those changes and understand what their core emotional needs are. I find, at least in our military, we don't teach soldiers about their emotions. And so they might not have had any understanding about their emotions earlier in life. And then they come into the military and they're taught to shut down and shut off their emotions. But naturally, when you serve in the military, you feel lots of things. That's where it comes from. We have feelings about particular events. But soldiers aren't trained, they don't know what to do with those feelings and how to manage them. So the schema therapy helps understand, oh, these are my emotions, and my emotions tell me what my needs are. And if I understand what my needs are, then I can understand how to get them met my life now. And that's really how we work with them, to help them understand, their beliefs, what's helpful and not helpful, their behaviors, and then their core emotional needs and how they can get them met.
Well, how exactly practically do you do this?
Okay, so there's a couple of different techniques that we use in schema therapy. One of the techniques we use is reparenting, which is really a lot about education and awareness. So teaching the person about their emotions and what they're feeling and why they're feeling it. So in particular, anger is a particularly difficult emotion for military people because they're trained to fight. So we educate them about anger. We teach them how to feel it in their body and understand what's happening in their body. So when I feel anger, I feel hot, I feel tense, I feel, these different things in my body. And then they've been trained to use that to go to a fight response, because again, that's required in operational service and combat. And so, but we don't want them going on an attack. And being at home and having that anger and channeling it to an attack at a partner or a child or somebody. So we teach them that they're feeling anger in their body and then how to manage that anger differently. So instead of going into an attack, which is a behavior, we teach them to come into their bodies and learn how to breathe, how to regulate, how to understand what they're feeling and why they're feeling that way and how to manage that emotion. So that's one of the techniques. Another one of the techniques that we use is imagery. And with imagery, your brain has the capacity to, it doesn't differentiate real from imagined. So we can use imagery to go back to particular events that might be difficult. We don't go through the trauma. We go back to the point where the trauma occurred. And then we can change the ending, create a different ending for them, or at least help them get their emotional needs met. So an example of this is I had one of my soldiers that was involved in an IED blast. His section commander didn't step up in that moment and perform his duty that he needed to perform. So we re-scripted that image and brought in the section commander that he really needed there at that time. And we were able to sort of manage that traumatic event for him by helping him process what he felt about that event and why he felt it. And we changed the ending so that when that event comes up, he can see the ending that he wants to see, which is with the section commander that he wanted, rather than the ending that was there, where he was left quite abandoned in that moment.
But that means that he has to imagine something, or isn't it? I don't know. I don't do psychology, and I'm not. I haven't been in combat, but I would imagine that it would be bad. I don't know, that to teach him that you are that he's here in the right now, and that this is actually the ending, that he's back in Australia, or that he has seen his family. And
yeah, we very much do that as well. So yeah, that is part of it. But sometimes with trauma, you actually get stuck in trauma world. So your brain can't process that event. So it actually stays stuck in trauma world. So the reason to do the script is to be able to change the ending, to process the traumatic memory, to clear it out of the trauma center, and then bring them back to the here and now, and connect them back to the things in their life now. I find military people are very disconnected emotionally because, again, they have to be for service life to do their job. So connecting them back emotionally after service is a really important part of the process. But to do that, they need to feel. But to feel, they need to understand their feelings, and they need to process any of the feelings that haven't been processed during service.
what else do you do?
So there's two other techniques. One of them is called chair work. And chair work is a technique that basically we have an empty chair, and we get them to put a part of themselves on the chair. So this increases awareness of the self. We're one person, but we have different parts to ourselves. So we can take like the military part of themselves and put it on a chair and help them talk to that part and help them resolve any conflict that they may have, guilt regarding actions that they did or didn't take, or particular outcomes. And with that, we can help them develop some compassion for themselves. We can help them to set some limits on themselves and help them to recognize that part that did their service, which I find is very important for military people to be able to recognize. I see you, I know what you've done. I'm proud of you for the things that you did, and you know that you did your best. And they can develop that self-compassion and connectedness within themselves and come to forgive or honor or respect or value the part of them that did serve. And it can also help us to develop the part of them that does need to be more connected, so they don't just have the soldier part. So we work with the part before the military, the part in the military, and the part now, to help them understand these different parts of themselves and how to connect them all back up to be a whole person again who can function in the here and now in their life now.
And you said that you felt very restricted in your training with cognitive behavior therapy. Is that, was that because of your training and that you all work in this kind of lines of your therapeutic rules, or you just didn't know?
Probably a little bit of both. In our training here in Australia, it is very, well, our system in Australia certainly encourages a very structured approach, and cognitive behavioral therapy is a very structured approach. It's getting people to focus on thoughts and challenging thoughts. So I think trying to just focus on thoughts and behaviors and challenge them in the expectation and hope it's going to change the way the person feels, I think is incredibly limited. Whereas schema therapy, we can help them understand what they're feeling and why. So instead of just trying to change the way they think or act and hope that that changes the feelings, we want to be able to instead change, help them understand what they're feeling and why, and take a more emotion focused approach.
And how long does therapy take with you?
Schema therapy takes much longer. Yes. So schema therapy is a much more longer term therapy. You know, for me to have a client come see me and reach a point where we have some particular outcomes, you know, that are quite good and where they're quite stable, it can take me a year, where I've, you know, worked with them consistently for a year to be able to stabilize their symptoms, their PTSD symptoms, and help them reach a point where they're more able to function in the community and move on. But, you know, generally I find it takes a good 2 years after service before, you know, they're really well. But in that second year, therapy is much more reduced. It might be once a month instead of every week or fortnight. So it's much more reduced, and it's just designed to sort of help them integrate back into the community and really find their way forward. So that, you know, I guess that could be used as an example. But if there is childhood trauma, then of course they'll be in therapy for much longer, because that will need to be addressed as well.
But this is not connected to the combat PTSD, no?
Well, I think it is. The military does attract a large percentage of people with adverse childhood experiences. So I actually question that the military actually attracts people in, you know, that perhaps have a set of unmet core needs and already have a set of schemas. That's some of the research that I hope to be able to do moving forward, because I think that the military attracts a certain type of person in. But yeah, in Australia, and I know also in the US and UK, the military, many people that come in have adverse childhood experiences. So I do think that that is part of the picture. But what I find with my work is we have to address what's happened in the military first, and then you have to go back and check what happened in the life before the military, and then that all starts to connect up to think about where the person is now and where they want to go.
Can you say this more explicit? What kind of types of people might attract us, and why would people?
Well, I think to serve in the military, I think you have to have very high standards. And of course, I'm basing most of this off the Australian culture. I haven't looked at other cultures across the world yet. But I think, you know, particularly in our culture, I think the with very sort of very willing beyond impulse. People are so willing to sacrifice, who are, sorry, my connection is unstable. Hopefully it's okay. I think people who are willing to sacrifice themselves, you know, to put the organization first, who are willing to serve the organization and do whatever it takes. So I think, you know, people that come from a background where they haven't had a strong, close family, they really come seeking that, and they really get that from the military, that close connectedness, that sense of belonging, that sense of, you know, I belong here, and they want to serve the organization, they want to do well. And I think that they're the type of people that are being attracted into the military.
But what kind of childhood trauma could you have if you have a strong family?
I think, well, I don't know, you know, I'd question some of that. You know, I think you can come from a military family, so that's where it comes from. The desire to serve, it comes from the military family. So that's probably a little bit like me, where it was honored and respected. And it can come from that. Whereas other families, you know, I know clients, a lot of my clients have come from, you know, really difficult backgrounds where they haven't had a strong family. You know, one of my clients would have ended up, it was jail or the military, you know, he joined the military. I don't think that there's a set, and as I say, I hope to do some research on this one day. I couldn't tell you, I don't think that there's one set family, but I do think perhaps that there's a set of schemas that are quite prevalent, and that would then tell us more information.
But in general, that's not a bad thing, no? I mean,
no, I don't.
It's like, I mean, there's not a scheme for people who want to become first aid workers or police.
Well, I think everybody's got schemas at the end of the day. You know, I don't think that there's a perfect parent who can perfectly meet every child's core needs. So I do think that, you know, I think we've all got schemas. And I think it's just understanding that, you know, we have particular personalities, we have particular backgrounds. Schemas only become a problem when they really start to disrupt your life, where you're not able to really function outside of that, where they're very rigid. And that's part of it, is understanding your schemas and how they work for you and don't work for you in your life.
What do you work future based, like what they going to do next in their career?
Very much so. Very much so. I see that as a really important part of the therapy process, again, to understand who were you before the military, who were you in the military, and who you want to become now. I think that the military gives you an identity. They, you know, when you join, you get given an identity, and that feels very safe and secure, and it feels really nice. But, you know, when you leave the military, you need to figure out who you are and where your place is in the world. And that's a process that they need to undergo to be able to explore and understand that. And I think it's a very important part. I actually think that that's more important. I spend more time helping them understand these things than I do on working with their trauma, because I find when we do these things, the trauma more naturally resolves itself, because they're making sense of themselves and what's happened to them, where they've come from and where they're going.
So most of people don't know what they're doing, going to do after they leave military.
Yeah, and I don't think that they meant to know. I think that it generally takes, from my experience, a good 2 years. to sort of undo the not so good things about military and figure out who they are now and what they want to do. So I think that because it's a really a learning and growth process that actually needs to occur, the military more so conditions you to be a particular way to serve the organization. And they do this in a developmental period. So, you know, in Australia, people join the military between 17 and 25 years. And that's a key developmental period when we're meant to figure out who we are and where we belong in this world. Well, in this key developmental period, you're given all those answers to all those existential questions. You're told, well, you're a soldier and you belong in the military world, and this is how the world functions. So when you step outside of the military, you need to be able to make sense and develop new understandings about yourself and the world. And again, I see that as the most important part of the process, and currently the missing link for military personnel. I think that's what we're missing at the moment, and that's what needs more focus.
Can you tell me, do you work with non-adaptive coping thoughts? Can you explain what this is?
Yeah, so beliefs and behaviors developed in the military, they can be adaptive, but they can certainly be maladaptive, you know. So a maladaptive coping behavior, you know, will, I guess I see even the soldier as being a coping mode. It's a way of coping, it's a way of dealing with military life. It's very adaptive when you're in service, but it's not adaptive when you leave, because it's only designed to work and operate in the military environment. So coping modes can be adaptive, where they work for you and then can become maladaptive. So when it's in service, it's very adaptive. Outside of service, it can be very maladaptive. So you might be a parent in your home and you're treating your children like soldiers. That's a maladaptive example of your military mode. Was used in service to command soldiers and, you know, manage the military, but then you come home and you treat your wife or your partner or your children, you know, like they're in the military as well. And that's not adaptive, because that doesn't foster relationships or connection or harmony. It you know, it's more brutal and rigid and scolding.
What is rumination?
Rumination is where we basically end up fixated on a set of thoughts or a situation. So we just end up stuck and we ruminate on it. We stay stuck on it. We replay it over and over. So it could be a thought, it could be a trauma memory, it really could be anything.
Psychologists in conflict areas while they're there?
Yes, we do. And they're not out in combat, but they are in the bases. So we had psychologists located in Tarankaut when there were obviously soldiers in Afghanistan.
And what would you recommend people how to from the military, how to deal with their memories?
I think that they need to find themselves a very good psychologist who's willing to help them make sense of it. I think that current best practice is focused on desensitization strategies or EMDR as best practice. I again find those quite limiting, and I think that it's more than just exposing. I find military people very able to talk about their traumatic experiences, so it's not so much them needing to desensitize it, because they can talk about what they've done and what happened to them, so they can tell the story very well, and they generally desensitize themselves by talking to each other. what I tend to find is they not so good at is the emotions that they feel and making sense. So, you know, when I worked with military personnel, a lot of the traumatic moments, you know, were actually okay for them because they were well trained and prepared for them. But the things that were coming up was that I got stuck before I kicked in that door, you know, or I shot that guy, but I didn't get to check the bodies, and I can't, you know, really be sure that he's dead because I didn't get to check the body, you know, or that I froze in that moment. So they're very specific, you know, and they're the things you can desensitize that memory, but unless you make sense of where the actual stuck point is and what's happening for them, they can't process their memories. So I think that they need to find a good psychologist who will help them understand and process and make sense of their military experiences.
So there's different approaches for certain people. Some, for example, some might just accept it, or some take a different view on it now, and some other person should do this, or yeah, that's the most healthiest for their.
That's right. And that's the thing. They all need different things at the end of the day, because again, those core needs have been met and unmet to different degrees for different people. So what each person needs will definitely be slightly different. But that's the great thing about the schema therapy model, is it gives us a framework to be able to operate from, which makes it easier, because we know that there are five groups of core emotional needs, and therefore everything's going to come back to one of those needs. It's almost like, you know, when you raise a baby, it's going to be one of five things that the baby's crying that's upsetting them. You know, with these core needs, we know it's going to be one of these core needs that's causing the difficulties for the person. If we can figure that out, what that need is, then we can help make sense of it and help them work out how to get that core need met to be able to, you know, resolve the trauma and move on.
So you categorize people in. You also work in the with this test book, with this book that has different, what's it called, where you can see what kind of psychologist problems.
I'm not sure.
Mm.
Not so much. I mean, the schema therapy model just gives a framework, you know. So it says that everybody has these core emotional needs, and that's just known through research on children in childhood. And when that core need is unmet, it creates a schema, and the schema is the belief system that they create about themselves, others, or the world, and then they've got to cope with that, and that's the behavior that comes out. So it's not so much, I mean, there's schema textbooks, there's schema books around, but it's just understanding that, you know, when these things, I guess when there is trauma around, I guess from a schema perspective, our view is that that's because there's some unmet emotional needs there. And if we can figure out what the unmet emotional needs are, then we can respond and help the person.
So yeah, but you categorize from that. You said you have a scheme, so there's maybe a happy person, and then there's this detached protector, and complainant surrender, and then you have a kind of a list, a scheme, a certain treatment.
Yep. Well, yeah, they're some of the different coping modes. That's right. So we have these different coping modes, and again, everybody has these different coping modes where we, you know, detach from emotions, or we soothe them with drugs or alcohol, or yeah, we surrender to avoid conflict or confrontation with others. So these are, yeah, just particular coping modes that people do have and do use. We all do. And again, schema therapy helps you understand these behaviors. Why, do you detach from emotions? Maybe I learned that they're bad, maybe some point in my life, I learned that they're bad, and or that I'm bad for having them. So I develop a belief system around that. And then I might detach from them to cope with that. So I might learn, oh, if I just detach from my emotions and don't have any emotions, well, that's how I survive the world. That's them. Then I'm acceptable. People accept me, or I can manage without having these emotions. It's very adaptive. It can help the person in their life, but it's maladaptive because the person has no connection. So that core need for connection isn't being met. And if that core need for connection isn't being met, then they feel very lonely and very alone. And so we can't be okay. We can't be happy and healthy and calm in our life because we're feeling pain from being disconnected.
Do you work with people with comorbidity as well?
All the time. Yes, all the time.
And do they need something else a different time? But because sometimes people have two different therapies at one time.
I don't find, I just use schema therapy. That's all I use, because if someone is drinking alcohol or using drugs, that can be conceptualized as that detached self-soother mode, where they're using the substance to soothe their emotions. Well, if we can understand the emotions, and again, what the need is behind the emotions, then we can do something else. So I don't believe you need anything else. I find the schema model can, you can incorporate other therapies into it. Sometimes I incorporate mindfulness into my work. I incorporate, values into my work. But the schema therapy to address the comorbidities, I find is enough, because again, it's just another behavior that the person is doing to cope with emotionally what's going on for them.
What is, do you also use Gestalt therapy? Is that a part of this?
Gestalt therapies are incorporated into schema therapy, and that's part of the chair work. The chair work technique that I was talking about earlier is a Gestalt therapy technique. And it's where you use those elements and theatrical elements in to help create a change and a shift in the therapy space in some way.
Can you also use creative therapy, like
yeah, very much so.
So you can you also paint with patients sometimes.
Yeah, but that's the thing, when you've got the model and you understand, I guess, what's happening for that person and what they need, you can bring in any other therapy into schema therapy. So, if they need to practice expressing, one of the core needs is freedom to express valid needs and emotions. Well, if they find that they can express through paint or music or writing or poetry, well, of course, we would be encouraging that as part of our therapy process. We'd be talking about the emotion that's happening for them and exploring that, but we would be encouraging the expression of the emotion. But we also have spontaneity, fun, and play as another core need. So, of course, we'd be encouraging having some fun and play. I play games in therapy with my clients sometimes, just to encourage having that core need met and that experience.
What does the therapy mean with uniting the affective, cognitive, behavioral, and psychological system within a person?
I'm not sure. I think, I'm not sure where you're reading from, but I think it's about, again, the affective is the emotion. Obviously, the cognition is the thoughts. So in this type of therapy, we're trying to help them understand the emotion and the thoughts. Cognitive behavior therapy is focused on, here are these thoughts and here are these behaviors. And we just make an assumption that if we challenge the thoughts and the behaviors, we can change the emotion. Whereas schema therapy is very much about the emotion, and it's central to it.
But what can you give a practical example of challenging thoughts?
Well, in cognitive behavioral therapy and schema therapy, we can challenge a thought. So, I mean, let's take the thought, I am bad. Okay, so that's a thought that a person might have, I am bad. In cognitive behavior therapy, we would look at the evidence for that thought, the facts for that thought, whether that thought's helpful or not helpful, and we would try and come up with a more balanced thought than that thought. In schema therapy, we would say, where did you learn this thought? Where did this thought come from? When was the first time you had this thought? What was happening? What happens when this thought comes into your mind? What's going on for you, and what does that remind you of? Because we want to source it right back to where it originated from, and then we can again correct it. So maybe when they were a child, a parent said to them, you are bad, and then they had that thought, which has turned into a belief, I am bad. Well, challenging the thought, looking for the pros and cons for it, and the facts around it and the evidence to support it and not support it, well, I'm only going to get so far. Whereas if I go to the source of it, oh, your mother told you that you were bad when you were little, then we can actually correct that. And we can actually say, well, you might have done a bad thing, but you're not a bad person, and we can actually help them change the way that that's been stored in their brain.
Do you include family systems? Like, do you include partners? And is that included in your therapy? That are partners?
Everybody.
Your family, the spectrum, basically. Is that
look? Everybody works differently. And in different ways. I often include partners. That's probably the most, not so much the family as a system. But in my work, I'll often include the partners, not all the time or every session, because I don't really do relationship counseling. But I include the partners in some sessions to help them work on the relationship and their connectedness. But again, different schema therapists work in different ways. Some will not, others will do couple counseling. So everybody does work a little bit differently.
Is that involved in cognitive behavior therapy? Working, including the partners or the spectrum around you, and what?
That's more, it's more an individual clinician than a therapy. So that's not structured into the therapy. Different therapies, there are people, relationship and family counselors that use cognitive behavior therapy. So it's not so much the therapy that dictates that, it's more the psychologist, the individual.
And how does this, so the patient comes to you and tells you, now I feel this and this, and then you do you also ask in what situations do you work on, like in the here, right, and now, and what happens when you, and where does it happen, and like how should I react?
Very much so. So we work on the here and now. So this event happened to me. So the person might come in and say, in the past week, I had this fight with my partner. So this event that happened in the now. And we'll talk about that event and then get them to connect to how they feel about that event. And we'll explore what thoughts they have in relation to that event and what behaviors they had. And then we'll get them to think about, well, when did you feel like this before? When else have you felt like this? What is this feeling connected to? Maybe my partner had to go away for work and I got really angry with him. Okay, so maybe I was feeling abandoned. And so we might sort of help the person be able to understand that in that moment when my partner was leaving, it triggered my abandonment schema. I felt very alone, and I'd link that again to other experiences in my life when I was abandoned. And then again, we can correct them at the source where they originated rather than just in here and now. So we go back and correct it. And then we come back into the here and now. So the person is able to say, oh, my partner's just going away for work. I'm not being abandoned. That's what my child part felt, because I was abandoned as a child, but I'm here now and this situation is different to them. And that's my partner just going away for work, not abandoning me. So by understanding it, you can make more sense of it and manage it differently.
So it also can happen because you said lots of veterans talk or write a lot about their past and their about their experience in conflict, and but could that be that there may be emotions that they felt in this story, but they don't associate this with the story, and it's just a feeling that turns up, like it's disconnected from the story or from the memory from the story?
Yeah, I do find that a lot, that they can write and they can talk about it, but they're not so good at understanding the feelings around it, unfortunately. I think that military people also need recognition of the service. And I think that when they write about it and talk about it, it gives them a sense of being recognized, because it's important to them to have their service recognized in some way. So again, there's probably a need there. Maybe they need someone to hear them. Maybe they need someone to validate them. Maybe they need someone to forgive them. There's definitely, I would say, something happening in that emotional space as to why they're doing that. And understanding that again would be useful for them as to why are they writing about it? Why are they talking about it? Why are they ruminating on it? Because there's a reason that that's happening. It's not just happening because there's a reason why it's happening.
That they write and tell their stories.
Yeah, I think so. I think that there's a reason that they do that. Again, that reason can be different, but I think it comes from a need within them, for that reason, for them to write and tell their story.
But so you think it's not always a good thing? No.
I guess always a good thing, but because it might be the way that they get that need met, and they might not be able to get that need met any other way. The need to be heard, the need to be recognized, the need to be validated, the need justice. They might not be able to get that need met any other way. It does depend on why they're doing it. What is the purpose?
Because
if one of my veterans was writing a book, I would just really get them to think about why would they want to do that? What is the reason and the purpose? Because if they go through that process, we want them to get that outcome we need to be met, not write the book and then not feel anything at the end of it.
Mm. I never, I thought, I never, me as a researcher, I think that you'd want to write a book to share your memories, no?
Yeah,
Or
that could be it as well. That could definitely be the reason as well. But again, there's really a reason behind every behavior. I mean, that need to share, that's still a need. It's a need that person has to share their story. It's not a bad thing, you know. It's just a need that person has, and if they can acknowledge that need that they have and get that need met in a healthy way, that's a good thing.
what's integral psychotherapy?
Can you say that again? Sorry.
Trans-theoretical mode.
I'm not sure what that is. Sorry.
And integral psychotherapy.
I'm not sure. Sorry.
Oh, I made notes about Schema therapy.
Well, schema therapy is an integrative therapy, which means that you can integrate other therapies into it. So it's an integrative therapy because you can incorporate other therapies into it.
Do you prescribe medication?
No, psychologists cannot prescribe medication. So only psychiatrists can prescribe medication. So our role is to help them understand their thoughts, feelings, and behaviors, whereas psychiatrists diagnose and treat medical conditions predominantly with medications.
And do you treat patients who are on medication?
Yep. Yeah, I will if they're if they're on medication. We do need to consider what effect the medication is having, because if they're on antipsychotics or benzos, it's going to numb the emotions, and that will limit therapy outcomes. So you need to be mindful of what medication the person's on, because they can't process emotions if the emotions are being numbed. But some medications can help stabilize the individual enough to be able to do the work that they need to do in therapy.
And why is common theoretical language so important?
I guess it depends on the context. I'm not sure what context you're asking that, but I mean, having a shared understanding of what's happening for the person allows us to be able to manage and treat the person.
How long, what are you doing in the assessment phase in the therapy, and how long does it take?
Well, the assessment phase can take a couple of sessions. Again, it really just depends on the client. But yeah, it can take a number of sessions, and in that phase we're trying to understand what's happened to the person. We get a military history, understanding when they joined and when they left and why they left and when they deployed and where, and just have a general overview of their military history. And then we'd want a background history, so that again, their life before military, we'd want to understand that. Family dynamics, social dynamics, and then sort of what's going on in their life now. So the assessment can be quite thorough and be done over a number of sessions.
And then you and there's a schema you work from as well.
There's a schema questionnaire, that we can administer to people that will help give us a schema profile and understand what schemas that person has. And then again, we can educate them on that and help them understand it, and then work to correct those schemas.
And what are cognitive distortions?
They're thoughts that are called distorted thinking patterns. So they're just disordered thoughts. So again, a thought such as I am bad or I am weak would be considered a disordered thought, a thought distortion.
I'm trying to come up with more questions that could be helpful for a veteran that reads the magazine. I did interview the VA, the US American, and the British army psychologist, and the German army hospital. And I'm horrible. Yeah, I'm not. Yeah. So.
Well, I think a lot of people focus on combat stress, on PTSD, on the trauma. And I think it's only one small percentage of the picture. I guess that's the thing that's different from my view, is that a big focus that from my point of view is, again, what happened to you in your military career and how did that shape you, and understanding that. So I guess that's the difference between the way I work and the way a lot of other treatment centers for veterans currently do work, because they are very focused on PTSD and trauma.
And can you get other dysfunctions or problems because of your military or combat deployments, like bipolarity, or I don't know, other something like depression, or that is not PTSD?
Very much, yeah, of course. I think that you can have definitely other disorders. You can have anxiety, you can have depression, you can have substance abuse problems. I think you can have all sorts of problems. And again, I think that that's part of the problem, just focusing on, trauma and PTSD, because I think it's only one part of the problem. I think it's the symptom, not the cause. Again, schema therapy likes to focus on what's the cause, where did this originate, and why, and understanding that allows us to again correct it and change the path moving forward.
So, and what does PTSD look like? Is that just being sad or being angry, or?
No, PTSD has a range of symptoms. So they basically, you've got to have been exposed to some sort of traumatic event. And then after that traumatic event, you would have re-experiencing symptoms, and re-experiencing symptoms of thoughts, feelings, images, nightmares, flashbacks that occur where your brain's trying to make sense of what happened to you. So you have these re-experiencing symptoms occur. And because it's very unpleasant and unwanted, then you want to avoid those symptoms. So then you have avoidance symptoms, where you avoid going to places or people or things that remind you of the trauma, or you avoid emotions, or you withdraw. And then you end up with hyperarousal symptoms. So feeling very edgy, alert, on guard, hypervigilant, difficulties concentrating and sleeping. So PTSD is grouped into these categories of re-experiencing symptoms, avoidance symptoms, and hyperarousal symptoms. And you have to see symptoms in each of those clusters to be diagnosed with PTSD. Whereas depression is low mood, loss of interest or pleasure in things, and low mood for a period of 2 weeks or more. And there's symptoms that come in under that, but the big focus for depression is on this low income pleasure. PTSD there was this traumatic event, and I have these experiencing avoidance and hyperarousal symptoms.
Are the hyperarousal symptoms always attached to memories of certain situations, or can they just be something else now?
Well, the hyperarousal symptoms are just in your day-to-day. So jumpy, easily startled, difficulty sleeping. They don't have to be attached to the trauma. They generally are, but the experiencing symptoms are generally attached to the trauma. It's all part of the picture, but the hyperarousal symptoms can be just if someone startles you, if they walk up behind you.
What do you tell the veterans about life and relationships, or dealing with relationships? Tell them everything, or?
Well, there's no right answer there. It just comes down. I think what's really important in the relationship is education, awareness, and understanding. So I think it's important for the veterans and their partners to be able to understand what's happening and communicate about what's happening. I don't think that they necessarily need to know what happened in the trauma or in combat, but I do think that they need to understand what's going on for the person and their symptoms and what's happening to them and why, and help them also know how to respond in those moments.
Did you experience or could you see or did you change your learned trained behavior, that mechanisms that you learned in the army?
Yes, it was actually really important because I'd been trained in the army. I had a military mode as well. And unfortunately, that military mode as a psychologist would encourage a lot of the military behaviors, such as shutting down emotions and pushing through and getting on with things. And that was not helpful for me as a person or for the people that I was working with. So it really important for me to be able to work on my own things as well as them being able to help others.
What would you recommend then? What's the normal approach, if not just pulling through and function? And
it's stopping, slowing down, connecting to your body and what you're feeling and understanding what that is, regulating the emotions that come along with that, and then being able to respond to a situation rather than just react to it.
But in what situations would then a person that is just pulling through know that this is wrong? I mean, what the society, another person then tell the person you're doing something wrong? Or, I mean,
it's not so much about doing something wrong, but you might have a person that gets very angry and loses control of their anger and has an outburst. Generally the person doesn't understand or like that very much. Sorry, can you just give me one moment?
Yeah.
Oh, just 1 minute. Sorry about that. I don't think it's so much about doing something wrong or getting something wrong. I think it's about the person, perhaps reacting in particular situations where they have a particular behavior where they don't like it, and then wanting to learn a different way of doing that thing. They might be in their relationship and getting angry at a partner or a child, and the partner might say to them, you need to go and sort that out. You need to learn a different way of dealing with your anger. So that would be a motivating factor to engage in therapy, to learn to do something else, to learn how to address the emotion that they're feeling rather than just react to it.
Do you have lots of problems with suicide, like in the USA?
Yeah, there is a big problem. We're having a royal commission into veteran suicide at the moment that recently started, because yes, there is a big problem with veteran suicide in Australia at the moment, and it is something that's currently being investigated, and requires attention, definitely.
What do you mean by investigators?
Well, there's a royal commission. So the government here has determined that there is a problem with veteran suiciding, and so they're conducting an investigation into why there are so many veteran suicide. That's being conducted at a government level in Australia.
Okay, Megan. I thank you so much. I'm sorry, it's 7 o'clock. Thank you much. You have birds, no?
Yeah, I hope it wasn't too noisy in the background. Sorry.
No, it's lovely.